Yeah.
We're going to talk today about Carrie's scoliosis and scoliosis in general. Scoliosis is a condition where you get a lateral curvature of the spine. It can be either genetic or it can be functional. Genetic is one where there is a family history of scoliosis. Also, the more common one though that we run into is functional. And in most cases, even the genetic becomes a functional aspect because of the way the muscles have to strengthen themselves to support the spine. We showed you a couple weeks ago on a video that one of the exercises that we perform in our fundamental movement therapy classes with the gyrotonic machine, when we had Carrie actually do spinal rotation. This is one way that we treat the strengthening of the muscles as we start to correct the scoliosis in general. The goal is to get the spine to actually create the rotation and eliminate the forced movement of the rib cage. That is what normally causes the majority of the pain, is that the rib cage is forced movement. This forced movement then creates disruption at the joints, the facet joints of the spine itself. And that's where the ribs actually tie into the vertebral column, or the vertebrae, forcing then inflammation in the costal cartilage that attaches the front part of the rib to the breastbone or the sternum. So what we're going to do is, a lot of people, when they come in, they'll say, well, can you get rid of the curvature? It's hard to sometimes get rid of this curvature that some people have had all their life because of the way the muscles are strengthened. So what we're going to do is we're going to balance the muscles as they are right now. What this will do is we'll take tension off of the spine, affording the spine more mobility and more of a motile or spontaneous movement. This spontaneous movement is what's going to start to reverse some of the strengthening fibers, and the side that is weak will then have an opportunity to become stronger. So what we're going to do is Carrie's to the right, and then just below the scapula line, it starts to go back to the left. So these muscles here are going to be very strong to hold the spine here. These muscles are going to be very strong to hold the spine to the left. So what we need to do is we need to create more of a balanced tension between the right and the left here, and the left and the right in this area here. That will then cause her spine to create more of a stable line. She's had this condition her entire life, so there's going to be a strong support or strong muscular pull on this side. We just need to diminish that pull to allow this side then to become stronger. How are we going to do this? Everybody says, well, I'm going to just work on these muscles here on the spine. That would be one approach, but it's probably not the most effective approach. The most effective approach is actually going to be able to stabilize Carrie from the ground up. So we're actually going to start working on her feet in order to stabilize her spine, so that this sacrum will actually lay in more of a horizontal position, so that L5-S1 can become the center of her movement instead of her center of movement being way up and through here. Okay, because this is where she's strongest. So we're going to force this forward tilt to the left ilium. As you can see from just touching through the diaphragm here, the left side of her diaphragm is very open and supple, where the right side, there's no movement at all. It also shows that her rib cage on the left side, on the upper portion, is protruding here, and on the bottom, right, there's protrusion. So here's her stabilizing the calcaneal bone. The reason being is on top of the calcaneal bone is the talus bone, which is a bone that is not, there is no muscular attachment to it, it's all ligaments. And these ligaments are what create the placement of the rest of the structure. It's also where the center line of gravity needs to flow through. So what Carrie's going to start to feel now is that her leg is rotating. You can speak also, Carrie, it's okay. So as you can see, there's very little movement on the outside. Most of that is happening internally. So she feels the whole leg actually rotating at this time. When she watches the video, she'll see that it wasn't rotating. Next, what we're going to do is we're going to stabilize what the bone is, the navicular bone and the cuboid. The cuboid, according to my philosophy of postural stabilization, is one of the cornerstone bones, one of the bones that actually locks in posture. You have 4 of them. You have the cuboid, the sacrum, the sternum, and the sphenoid bone. Those are the 4 bones that cause it. So what we're going to do is we're going to reposition these and take the tension off of it so that we can actually move the ankle and stabilize this right leg. And once again, there's a sensation of movement. And
now relief of pressure too.
Pardon?
It's a relief of pressure too on my ankle. Oh my God, her foot's moving.
Yeah, her foot's moving. This also gives her now a good ankle joint. Okay, now if you look, you'll already see that we now have a balance in the legs. So that 1/2 inch that there was in the beginning of the shortness is now balanced. So it's just a matter of repositioning that calcaneal bone, that cuboid navicular, now has reset the entire structure for us to finish our treatment of it. What we're going to do is we're going to put our finger on the medial aspect of the tibia bone, and we're going to hold upward on it. So you can actually see it just laying there. The other finger will go, my thumb is actually laying on the medial malleolus, or the inside ankle bone, and we're just going to hold that. Now what this is going to do is it's going to reposition the ligamentation that's holding it. So what Carrie is starting to feel already is a lot of rotation in the lower leg. And what this is doing is this is repositioning the ligaments. Remembering all movements start with the ligaments, and the ligaments provide stability, spacing, or positioning, movement, and then they control the speed of movement. So they're the ones that give the neurological messages to the tendon and the muscle to how much this tension is going to be placed on the bony structure. Now the leg is going to actually straighten itself. And when we check this now, we're going to find out that the right leg is now longer. Now the bones haven't grown in this short period of time. What is happening is we're starting to get a spacing in all the joints. Okay. Our next avenue is going to be the tibia, the femur bone, or the hip joint. Okay, now remembering from previous blogs, I talked about the knee being a turnbuckle. So as this turns one way, this needs to be able to turn the other way in order to create that posture. As you can tell, when I do that now, the whole leg turns as a unit. This might be a little tender. Just let your leg lay right on my hands.
Where are you touching?
Okay, my fingers on my right hand are on the basics, the tuberosities of the femur bone, just above the knee joint, and my left hand is actually in the top of the hip joint. And what we need to do is we need to create spacing. The right femur was jammed up against the top of the hip joint itself, right against the top of the acetabular. So what we're going to do is we're going to create that spacing there. And what Carrie should actually be feeling is the bone moving and relaxing in the hip joint.
My leg is straightening too.
So now we've actually got a hip joint. So now when I take and move the foot inward, you can actually see where the femur rotates laterally. And if we go lateral or with the foot, the leg will go inward. Feel the difference there? Okay. Next, what we're going to do is we're going to balance the knee joint. Now the knee joint's critical because of the ACL and the MCL. Okay, those are the two largest ligaments, and those are the ones that everybody hears about that all these athletes always tear and injure. And even the weekend athlete, when they go skiing, all of a sudden they catch a ski or they lose their edge and they tear their MCL or ACL. So it's that ligament that we're going to stabilize right now. And what we're going to do is we're going to put my left hand is once again going to be on the tuberosities of the femur bone, the large thigh bone. And what we're going to do is we're going to come to the medial aspect of the tibia bone, and I'm going to see which direction it wants to go.
That one hurts.
Yeah. This one can be very tender. This also is right where the bifurcation of the sciatic nerve goes down into the lower leg bone. Okay, so what her shin bone doesn't want to move medially or into the middle, it wants to move laterally to the outside. Now, Gary can tell you right now there's a lot of pressure. It seems like a lot of pressure. I will maintain the same pressure, but as the tension on the skeleton starts to abate and those ligaments start to reposition the joint, that same pressure will diminish as it already has. And Carrie should actually be able to be feeling a lot of movement.
Yeah, it is.
What do you feel in movement?
My knee and my lower leg is moving.
Okay. Now what does it feel like your whole leg is starting to do?
Just relax and release and straighten. Oh my God.
That's exactly what's happening.
And from the looks of our camera person, it's showing up pretty well on the camera. Okay. All right, so now that when we bend the knee, you see that there's a nice flexion here. If we bend the left knee, you can see that there's no stability here because of the foot. Okay, so this is a kind of a... And once we're done with both sides of this, we're going to actually have Carrie sit up and we're going to show you a picture of her again, so that you can kind of go back to where we were at in the beginning to where she's at now, and you'll see the change already in the scoliotic condition of her spine. What are you experiencing now, Karen?
I don't feel it as much in my back as I do in my legs still.
What do you feel on your back?
It's relaxing, but I don't feel movement to it.
Does it feel like my hand's moving?
Yeah, I guess that's probably my back then.
Probably. Okay. Go on. What are you feeling?
My hip, still tension in my hips.
So we're going to, once again, we're going to balance those two muscles together. Can you feel this one more?
Yeah.
Yeah.
This side, I feel it in my back more than my leg. And I can feel the pulsing in my back, right below your fingers.
And remember, connective tissue has a pulse of 40 beats per minute. And when the tissue starts to flow, it's going to have a pulsation to it, so that the therapist should actually be able to experience that pulsation too. And when that pulsation is done, you're either going to notice a lot of movement or absence of movement. This is going to be in the proper positioning. That's really moving, isn't it? Feel your whole rib cage going now? Go on. You can explain. What are you feeling?
And now it's just relaxed. It's a lot less pressure. Now it's moving in my back. I feel your hand going lower. not moving?
How does that pressure in the pelvis feel now?
Better. Much better.
Almost like gone now, huh?
Mm-hmm.
Okay, can you feel that rotation now?
Yes.
Okay. Her spine is actually rotating, and that's the scoliosis.
And so is my leg.
Ah, that was a nice release, wasn't it?
Now I really feel like my lower back is on the table.
It's a good thing. Now what we're going to do is we're going to take and we're going to finish stabilizing the sacrum. I'm going to place the sacrum, Carrie's sacrum in my hand, just let it lay there. And we're going to go right above the pubic bone, and we're just going to stabilize the sacrum while we move the four muscles of the pubic area. This mainly releases the pubiococcygeal muscle, which attaches to the pubic bone and then the coccyx bone. And this allows the sacrum then to find its normal rotation and allow L5, the last lumbar, to sit on top of it then. There. What are you experiencing now, Carrie?
Of release in my lower back pressure. So I don't know.
It's good enough.
Yeah, I don't know what's moving, but it's a lot of
Feels like
pressure relief. Oh my goodness.
Now, we talked in the beginning about Carrie's pelvis being rotated, and you can actually probably see a better idea of it now. My hand is laying right on top of the ilium. So what we're going to do is we're going to stabilize that now, and we're going to open up the pelvis, and then we'll have her sit. Okay, we're going to get you to bend your knees, both of them, and we're just going to hold tension. Now this is going to be working the cartilage, the symphysis pubis. It's also going to be working the all the ligamentation between the sacrum and the pubic bone, or the iliums, and also into the head of the femur, the greater trochanter. There. Now the pelvis is actually starting to let go. What are you experiencing here?
My right side just completely released itself, and I feel like it's probably where it's supposed to be now.
And there goes the left side. And Carrie's not going to have any control of this. I have become Dr. Spock here. Okay. So now when I lay my hands there, you'll notice in the balance, the majority of the problem now is up and through here. So this is the area that we're going to have to really focus on. And how we're going to do that is we're going to see which shoulder is more pronounced. So her left shoulder is coming more towards me. So what I'm going to do is I'm going to stabilize her shoulder by releasing one of the most complex joints in the body, the thumb. And what you're going to actually be able to see then is the arm is going to start to move. Just let it go. It's okay. There it goes. Just going to feel a weird sensation. Okay? Just a little scared, huh?
It just makes you a little dizzy.
Huh?
My body's confused.
Now, this is not me turning her hand. That is actually the compensation pattern that is developed to accommodate the scoliosis. speed.
It's just strange. It's moving and turning and
Just let it go. I know it's a weird feeling.
yeah, I keep trying to stop it because it doesn't seem like it should be moving.
Now you see that the left shoulder is now completely drawn back.
Just took a little longer.
And you should notice now that both shoulders look fairly level, and they should actually feel somewhat. Now this actually shows us the point of scoliosis on her back. Okay, where it was up here before, it was in both places before. The upper back now has stabilized itself, and we have this area here of concern. What we're going to do is we're going to go to that area of concern on her lower back. I'm going to place my fingertips in the actual facet joints. That's the joint or the articulation between the vertebrae and the rib. Now we're down around ribs 11, 12, 10, 9, and 8. Now those don't attach directly to the breastbone. The last two are what they call floating ribs. They're not attached at all up front. 10, 9, and 8 are actually attached by a cartilage that comes off the bottom of the breastbone, and that's what we're going to. So we're going to be releasing that. And all we're going to do is we're going to hold that. So I'm in the articulations on the back, and I'm just going to hold these ribs. And Carrie, I'll give you all the commentary you need to know.
It just feels like it's shifting lower.
And we're doing this first because the next step that we're going to take is we're going to actually free Carrie's lungs. But we had to do this first because we wouldn't be able to get the vertical movement of the lungs until we got this restriction of the lower attachments of the ligaments out of the way, corrected. There. Makes you feel real weird now. Huh? Okay, so in order to release the lungs, what we're going to do is underneath the clavicle, we're going to put our fingers on the superior ligaments that control the lungs, and on the bottom we're just going to go to the base of the rib cage here, and we're going to hold. And what this does is help create a vertical release. What you already started to notice the difference in the breathing pattern. Feel a little different on the left and the right.
Mm-hmm.
You can actually see the left side of her chest moving now, where the right side is stagnant. Is that visible in the camera? No?
Everything else is.
I don't feel this side moving at all. The right side.
And because Carrie's had this problem for so long, we're going to actually aid the lung in expanding and contracting. I guess you can see it now. And we've already done a preliminary assessment of Carrie a few weeks ago. And we found out one of her problems is that there's also some jaw issues that are preventing the spine from balancing itself, which means that her head is not sitting on top. Her skull's not sitting on top of her vertebrae. I don't want to say that her head's a little off balance.
Yes, you do.
So what we're going to do to help aid this is I'm going to pattern myself with her lung, and as it inhales, I'm going to open up her rib cage, and I'm going to hold that open while she exhales. And once I experience that the rib cage isn't opening anymore, I'll hold it, and then now as she inhales, I'll hold that at vertical, eccentric contraction, and as she exhales, I'm going to help the lung. Now, they will get dizzy from this because they're probably going to have more oxygen than they've ever experienced. Okay. How are you experiencing that, Karen?
It's like an extreme deep breath, and it feels like when you compress it when I'm exhaling, it's like more air has come out than I've ever experienced.
Remember, on the left lung, there's 2 chambers. We only have 2 chambers on the left side. On the right side, we have 3. The 2 on the left is only because of the heart, and to make room for the heart and the way it moves. There we go. Be done.
I just want to see. Sorry.
Okay. So do you want me to continue, Kathy? Okay.
End it.
Okay. What we're going to do is we're going to stop here, and then we'll continue on, and we'll show you how to release Carrie's neck and skull in our next session.